For a child with a neurodevelopmental disorder, the therapeutic decisions made in the first 3 years of life dictate their lifelong level of autonomy. Currently, medical science possesses no pharmacological agents capable of repairing core developmental deficits. No pill can generate structural language, and no injection can synthesize social logic. Yet the secondary behavioral symptoms that often accompany these disorders, severe hyperactivity, aggression, and rigid repetition, are profoundly destructive. These symptoms induce massive caregiver stress and act as a physical barrier, preventing the patient from participating in the very therapies designed to help them. To manage this, clinicians split the problem into two distinct tracks: constructing a baseline of environmental support for daily life and deploying acute medical interventions to suppress the symptoms that block progress. This two-track approach can be organized into a unified mental model, the clinical matrix. The x-axis defines baseline structural need, mapping the environmental support required based on intellectual disability severity. The y-axis represents acute behavioral disturbance, tracking disruptive symptoms from co-occurring conditions like autism. This two-axis approach reflects current global standards. This graphic comparing the DSM-5-TR and ICD-11 criteria shows that diagnosing intellectual disability now relies on identifying functional impairments in daily life, rather than relying solely on IQ scores. By mapping a patient onto this matrix, a clinician can stabilize the environment on the x-axis while neutralizing behavioral spikes on the y-axis, clearing the way for effective early intervention. Modern diagnostics no longer define the severity of an intellectual disability by rigid IQ thresholds. Instead, the focus has shifted to adaptive functioning. Adaptive functioning measures real-world competence across three domains: the conceptual skills needed to learn, the social skills needed to interact, and the practical skills required for daily physical independence. A patient mapping to the mild end of the spectrum may only require help with complex tasks, like managing a budget or making healthcare decisions, but they often retain the capacity for independent living. Moving toward moderate to severe needs, patients require active, ongoing support. They rely on caregivers for personal care routines, consistent communication, and safe navigation through the community. At the profound end of the baseline, the patient requires pervasive 24-hour support to guarantee their physical safety, frequently communicating through augmentative or alternative systems. Establishing this adaptive baseline is the prerequisite for treatment. If a patient's daily environment doesn't meet their structural needs, secondary therapies will not be effective. But a stable structural baseline is often not enough. Even when a child's environment is perfectly calibrated, their progress is frequently derailed by the acute symptoms tracked on the y-axis. These are the manifestations of co-occurring conditions: severe hyperactivity, acute aggression, self-injury, and highly rigid behaviors. These symptoms act as physiological barricades. This diagram maps the multiple disciplines involved in an early intervention program, all feeding into a central goal of development. Locked behind these behaviors are the actual treatments the child needs. A patient in a state of severe hyperactivity or aggression cannot sit at a table for speech therapy or focus on the motor tasks of occupational therapy. This dictates the exact role of pediatric psychopharmacology. These medications are not a cure for autism. Their function is to mechanically suppress specific behavioral barriers so that rehabilitation can occur. Managing these barriers requires a constant trade-off. For every medication, clinicians must weigh target symptom efficacy against significant adverse effect profiles. To target severe hyperactivity and inattention, clinicians frequently deploy stimulants and alpha-2 agonists, such as methylphenidate and guanfacine. These compounds require active monitoring for side effects, including increased irritability, transient sedation, and a potential to worsen repetitive behaviors. For compulsive and highly rigid behaviors, the pathway relies on selective serotonin reuptake inhibitors, or SSRIs, like fluoxetine and fluvoxamine. However, prescribing SSRIs to this population introduces specific activation risks, where the medication can actually trigger severe behavioral disinhibition and agitation. When a patient presents with severe aggression or self-injury, the intervention escalates to antipsychotics. Typical antipsychotics, like haloperidol, have been largely abandoned in modern pediatric practice due to the high risk of permanent neurological side effects, like tardive dyskinesia. The current standard of care utilizes atypical antipsychotics, such as risperidone. These suppress irritability effectively, but require strict monitoring for metabolic syndrome and severe weight gain. Because these risks are serious, evidence is paramount. It is exactly why clinicians dismiss alternative treatments, like secretin or high-dose vitamins, which have consistently failed rigorous placebo-controlled trials. Every pharmacological choice is an exercise in precision, trading a calculated medical risk to buy the patient the focus they need to learn. The clinical matrix succeeds when both tracks synthesize, the environment is stabilized on the x-axis, and targeted pharmacotherapy is suppressing the y-axis behavioral barriers. With the disruptions neutralized, the patient can smoothly enter a multidisciplinary program, shifting their developmental trajectory upward. Empirical data proves the value of early intervention. This scatterplot tracks 178 children with intellectual disabilities over 12 months. Children beginning comprehensive intervention before age 2 cluster in the top left quadrant, achieving developmental gains far exceeding those starting later. A medication cannot teach a child social logic or practical independence. Its role is solely to neutralize the physiological interference that prevents those skills from being absorbed during therapy. By utilizing the clinical matrix to manage adaptive needs and behavioral disruptions simultaneously, clinicians can fundamentally change a child's developmental path, maximizing their autonomy for the rest of their life.